Okay, again, just a message before we start. You have to know that the echo cases either in the OSCE stations or in the coding sheet, it will not be difficult. If they want to bring something, they might just bring something a little bit tricky. They brought like a zoom image or like unusual view. But for the diagnosis to pick it and to answer it correctly, you just need like to give you some time and to focus on the finding carefully. Inshallah, it will not be difficult to know what is the diagnosis. Even at least you can tell what's the finding, even if you could not conclude what is the diagnosis at the end, but at least there will be some finding very obvious that you can pick. So this is the sheet that you have, and you have to answer based on this. My advice for you, if there is a finding that it is very prominent and shining, you have to pick this one first. Don't go for, even especially in the OSCE, if you have faced any station echo, for example, he brought for you a Marfan syndrome or whatever. Don't go and comment about the LV size or LV function while you have very enlarged and aneurysmal ascending aorta. If you have like significant mitral prolapse or whatever. So start by the most important finding, and after that you go to the less important. So the second advice that you need to have like what they call it, like a photo memory for this sheet. So easily when you are in the exam, you know where is the diagnosis. For example, if you are looking for constrictive pericarditis, khalas, you go immediately, no need to spend time and looking where is the diagnosis in the sheet. Okay. I have given two talks before, like 2 years ago. That was for the F1, F2, and F3. So I did not bring, I think, any of the TEE. But for the F3, as what I hear from your colleague, the last 2 years, I think they brought some TEE in the exam. So I will start for giving you what you need to know. I believe that there is 3 views. And they can bring it. All of them are from the mid-esophagus. You don't need to. I don't think that transgastric gonna come to in the exam. So this is the first view from the TEE that you should be familiar with, which is the mid-esophagus 4-chamber view. It's similar to the apical 4-chamber that we have in the transthoracic, but it's upside down. So what you have here, this is the left atrium, this is the mitral valve, left ventricle, interatrial septum, RA, and tricuspid with RV. So this is the first view at 0 angle. It is a 4-chamber view mid-esophagus. The second view, it's the long axis. It's usually between like 110 to 130, 35, depend on the patient. This is what we call the long axis view. It's similar almost to the long parasternal or the 3-chamber. What you have here is the mitral valve. This is the left atrium, LV, and aortic valve ascending aorta. So this view is very important. And the third one that you need to know is the bicable. Bicable, you have here the intraatrial septum. This is the right atrium. This is the SVC. And this is the IVC, and here is the RA. This is small one is the Eustachian valve. So these 3 views, I believe, if they will bring a TEE, one of them might come in the exam. Tamam ya shabab? So now we'll start to go for the first case. I need somebody from you just to volunteer. First of all, tell me if you need further review. If any, I will make it the first one as just warming up. Tell me if it will be like interactive as there is on OSCE station, and after that we'll go based on the coding sheet. So this is the first case. I need a volunteer kindly to tell me. what's the finding and what more view and what more he want to know about this patient. I will give you a brief history. This is a 40-year-old female who's presented to you complaining of shortness of breath class 3. Okay. Anyone? If there is no volunteer, I can ask somebody just to.
Yeah, I'll volunteer, Doctor.
Yeah, go ahead, please.
So I'm looking at a long axis parasternal view,
Okay.
and it seems that the LV walls are thick and there's some degeneration, or at least the aortic valve looks like it's thickened, but opening well. The mitral valve, the annulus, probably has some mitral annular calcification, and there's a bright pericardium on the posterior side. The atrial size looks okay. The RVOT looks okay. And I'd like to see more views.
Excellent. Excellent to start. So your name, Dr. Afan?
And Dr. Bara.
Dr. Bara. Dr. Bara, he started to comment about what's the significant finding here in this view, which is the LVH and the aortic valve. As he mentioned, the aortic valve doesn't look normal here. It looks like thickened, calcified. We cannot comment on the opening, how good is it, because still we need more view. We need to see the color. Is there any flow acceleration, any turbulence across the valve? You might need to go over the short axis. So, but at least he mentioned the two significant finding here is the calcified aortic valve and the LVH, like you have moderate LVH in this patient. So this is the next view, Dr. Bara. This is a zoom view for the aortic valve. What you can see here.
So the leaflet motion also looks good, but there is a large calcific nodule, so significant focal calcification.
Okay.
Above that, in the anterior aspect of the aortic root, I'd like to see more views just to make sure.
Sure. I will show you the rest. This is the short axis. What can you see here?
It looks like there is a large cusp, probably bicuspid valve.
Okay, excellent.
And I think that the large calcification is probably the raphe at about 11 to 12 o'clock.
Excellent. Which cusp are fused together?
The non-coronary and the left.
Is it? So.
Oh, actually, left and right.
Yeah, exactly. This is the left and right. It's fused together with one raphe, which is the most common type of bicuspid aortic valve. This is the interatrial septum. So what you have near to it, it's the non-coronary cusp. And this is the left and this is the right. So it's right and left together. So this is the next. What do you see here?
Here, this is looking at the LVOT and aortic root.
What you notice here?
There's color aliasing, and I think it's just the turbulence. I'm not sure. I don't see any specific regurgitation.
Okay, at least there's a significant turbulence starting from the LVOT and going to the aortic. Am I right?
No.
This is the next three-chamber again. You have flow acceleration with turbulence and aliasing at the aortic valve. So this is the continuous wave Doppler.
Okay, so this is an apical 5-chamber view, and the CW across the aortic valve with a maximum velocity exceeding 4 centimeters per second, which indicates a severe obstruction along that line.
Okay, so the velocity it's almost 4, as you mentioned. The mean gradient is 36, while the max is 60. It's like achieving the severity criteria. So then the next, my advice in such a case, that whenever you have like more view that you can take, don't lose it. Especially if your patient is having significant symptoms, And for example, if you get a gradient of 30s and the velocity did not reach to 4, why the valve looks really like calcified or thickened, you need to spend more time and to take all the other views because you might be surprised from what we will face right now. So this is which view is this, Dr. Bara?
This is the suprasternal aortic arch.
Okay. You can see here now, again, how significant is the flow acceleration and the turbulence in the ascending aorta at the level of the aortic valve. Now, our technician, he just put the Doppler's signal, and you can see how significant the jump in the gradient. Now, the velocity, it's exceeding the 5. You have a mean gradient of 60 and a max gradient of 111. So what is your diagnosis as conclusion?
Severe aortic stenosis.
Based on the, please go back now to the sheet and tell me what, give me 4.
Okay. So I would code an enlarged LV size, a normal ejection, a normal hyperdynamic, and aortic, moderate to severe aortic stenosis حسب الcoding sheet. And I'm not sure if there's a bicuspid code.
There is a bicuspid.
A bicuspid, no, aortic structure bicuspid.
So if you want to comment, start by bicuspid aortic valve, moderately severe or severe aortic stenosis based on the sheet, and after that comment on the LVH, that the LV is thickened, hypertrophied, and at the end, if there is one more, you can comment about anything else like the LV function, LV size, whatever. So thank you, Dr. Omar.
Thank you.
Another volunteer, please. It's just a one view. Give me all the finding.
Yes.
And
Yes, Doctor.
Diagnosis. تفضل.
طيب الRB is dilated.
Okay.
There is reduced function RB. طيب وماكونيل sign. Pulmonary embolism.
Excellent.
وبريكاردال effusion mild.
Excellent.
I think that's it.
Okay, excellent. So could you describe what is the Macaulay sign for me, please? Dr. Hamid, or who is this?
حامد.
Yes,
yes.
تفضل يا حامد.
طيب ماكونيل sign في akinesis mid wall وhyperkinetic diabetes, reserving diabetes.
Excellent. You can see here clearly that from the apical fourth chamber, the RV is severely dilated. It's much bigger than the LV. Patient looks tachycardic here. As Dr. Hamid mentioned, you have akinetic basal to mid segment of the RV, while the apex of the RV is like bouncing and hyperkinetic. Also, the RV it looks impaired in the function, though that we need like sometimes to have a TAVI. We have the tissue Doppler to be sure about that. But visually, as he mentioned, the RV function looks down. What do you have in the right side of the screen, Dr. Mahmoud?
طيب هنا D shape RB, also enlarged RB chamber.
Okay, excellent. So this is not in the code, but this is just to like tell you that really the RV has a significant pressure. This is a fixed image. It's not a video, so but can give you a hint that the RV pressure is very high here. So
طيب, from the coding sheet, we can say that enlarged RA, enlarged RV.
Okay, but you can, and you are not seeing the RA well here, honestly, too. But if you want to code, there is 3 or 4 code. It's very clear, and you have mentioned it right now. You mentioned about the RV size, RV function, and you have a diagnosis and the pulmonary embolism, and you have also the pericardial effusion. I think this 4 code is more than enough.
Okay.
So, Third one. The next volunteer, take your time, look carefully, and tell me the most important finding here, please. يلا يا شباب. Anyone? طيب
طيب I will take it.
تفضل.
طيب I can see like there is VSD and there is a flyer leaflet, mitral valve.
طيب.
And
What is the view يا دكتور غافل؟
it looks like apical fourth chamber, but it's not complete.
It seems that you missed the first part of the lecture. Whenever you see this half circle here, that means this is a TAVI.
Transphalangeal.
Yes.
Yes.
Okay. So this is a TAE. This is like LV focus size. This is a four-chamber view. You could see here that the mitral valve is here, the tricuspid is here, but we are focusing on the left side of the heart.
Left sided, yes.
Right. So
But it's going to be like the same description of the apical fourth chamber
yeah,
almost.
exactly. It's the image is upside down. The RA, the LA is up and the LV is down. So what do you see, Dr. here?
A VSD, as I mentioned, and the mitral valve, the leaflet of the mitral valve, it's kind of prolapsing or flyer leaflet. I will consider it as flyer.
Okay. Any other opinion? So did you notice that? Yeah, happen.
Ruptured cordy.
It's not rupture cordy. So any other, or should I comment?
There's a thickening of the leaflet and destruction. It could be a vegetation.
Yeah, this is exactly that's what I need to hear. First of all, looks to the valve itself. This valve, does it look normal valve or no? Look to the posterior leaflet, it's very thick. So this valve is revered valve, revered mitral valve, okay? That's why you can see the anterior leaflet is moving while the posterior is fixed. Tamam? The other thing what you have mentioned, this is the most important in this view. What is this? You can appreciate that there is a mass. This mass does not have a regular shape. It's an equidense, ugly in shape. It's in the LA size, that making a destruction for this valve and making a significant mitral regurg. Am I right? So if there is a history, definitely that will be easier for you. If I mention to you that this patient having a valve surgery before and he came with a fever, weight loss, that will be easy, but you might have this picture in the coding sheet. So you need to comment now. You have repaired mitral valve in the sheath. You have what else in the mitral valve? There's a vegetation, am I right? There is a vegetation. As I mentioned, it's big size vegetation, and if we take the size of it, it will be more than centimeter. So this is a case of repaired mitral valve coming with vegetation and infective endocarditis. And after that, you can comment about the mitral regurg. Here it looks like moderate at least. Okay, so this is the fourth finding that you have to comment about it. But if you did not mention the repair, you will not lose any big mark. But you should mention that this is a vegetation and this is a case of infective endocarditis. So this movement does not look like a flyer leaflet. There is no, it's not even the cordy. This has irregular shape. Okay, and the position of these or the site of these is in the RA, so this is favoring that this is a vegetation rather than anything else. تمام يا شباب? So the cases of infective endocarditis is very important in the exam. And why I'm expecting if there is something to be TEE, because you know most of the cases will be missed by the transthoracic and will be diagnosed from the TEE. طيب كمل معنا يا دكتور. What do you see here? So you can see that the gradient across the mitral valve is high, am I right? Because the presence of this vegetation. The mean gradient is 9. So as per the coding sheet, you go and you see in the في مكان mitral valve, the last one is repaired mitral valve or mitral valve ring. You choose this one. You go for the vegetation and you choose it. And downstairs in the prosthetic valve, you can find there is abnormal high gradient. And at the end, as the whole picture, you conclude that this is a case of infective endocarditis. Tamam? Is it clear for everyone? Anyone has a question or something?
Any VSD, Dr. Yasser?
No, there is no VSD. This is just because of the view itself. But there is no VSD at all. Okay. So I just opened that, the box here, severe MRMS degenerative. Can you repeat the code? Type. The code, it will be here. Repaired mitral valve, vegetation, abnormal, high gradient, and the end, infective endocarditis. Tamam? طيب, next one. Okay. So this case has 2 or 3 views. So, yalla, next volunteer kindly.
Can I take this, Dr.
Yeah,
Yasser?
go ahead. تفضل. مين معي الله يعافيك؟
عبد الرحيم الزهران.
حياك الله عبد الرحيم. تفضل.
الله يسلمك. This patient is this view is parasternal long axis with dilated aortic sinus.
Okay, excellent.
A normal LV, and I need further view focused on the aortic root.
Excellent. Okay.
So we can see aortic root, and we can see a small shadow. It could be dissection flap, and there is malcoaptation of the aortic valve.
Okay.
So I need further view.
Okay.
Dilated aortic root by 4.9, so it's severely dilated.
Okay.
There is moderate severe AR.
Okay, excellent.
And
this is a zoomed view with apical
yeah,
pipe
of
chamber.
the
There is
also there is AR reaching almost mid ventricle.
That's fine. What about the shadow that you have seen in the first view? Can you see it here?
Yes, I can see it. It's I can say it is a dissection flap, and we need the TEE for this patient.
Excellent.
Or CT.
Before to go for the CT, is there any more view that you like to see in the transthoracic?
Suprasternal.
Other?
And also I need to compare to look at the mitral valve if it is like there is mitral valve prolapse in Marfan syndrome, so I can comment on.
Excellent approach, يعني عبد الرحيم. One more thing is the abdominal aorta during the transthoracic.
Yes.
So tell me, what do you see here?
This is the abdominal aorta, and it is clear that is dissection flap. Okay,
excellent. So before go to the CT or the TE, just by putting the probe in the abdomen and scanning the abdominal aorta, you can see, as Dr. Abdurrahim mentioned, there is a clear dissection flap coming. You can see that, or under false human beside each other. So conclude the case for me, please.
So I will comment on the most important.
Yes.
Aortic disease, aortic dissection,
Okay,
dilated aortic root,
Okay.
with code also Marfan syndrome, aortic severe, mild, moderate to severe aortic rigor.
Mhm.
Um,
I think this is fair enough.
normal LV, yes.
Okay, excellent, excellent. So this is a case of dissection of aorta, starting downstairs from the abdominal aorta and extending up to the arch, and this patient was unfortunate. So it's extend to the carotid up and to the iliac downstairs. We took the patient, CT was done, and as you could see here, this is the dissection that's coming from the aortic root up to the arch, going down to the abdominal aorta and descending thoracic, and this is from down. Here it's extended up to the carotid, and here in the iliac. Patient was taken to the OR, alhamdulillah, and he was able to make it, and successfully we repaired. طيب. طيب. This case يلا يا شباب. طبعا في الاوسكيشن you might face like such a case. I'm not sure about the coding في الحالات اللي تكون فيها coding sheet, لكن in any of the station في الأوسكي they might start with you by the what is this? By the diastology. تمام؟ So يلا واحد من الشباب الله يعطيكم العافية. Come on, it's an easy case. Just take your time. Take it one by one. Still, there is another 2D view. We can see it after. But I need somebody to tell me about these
I will take it يا دكتور ياسر.
اتفضل. مين معي الله يعافيك؟
معك مشاري بقيمة دكتور.
حياك الله مشاري. تفضل.
الله يحييك. So this is Doppler showing CW diastology of and the BW.
Yes, BW wave.
And there is looks like a restrictive pattern.
Okay.
With a grade 2 to 3 diastolic dysfunction. I can see there is some pericardial effusion.
pericardial لا خليك من اللي انت just comment على البالس ويف وعلى السي دبليو داونستير. احنا we'll go to the 2D later on.
With so, E elevated at 10.
طيب, you have mentioned that the E over A here is 2.3.
Yes.
Okay, so this is either to be like stage 3 or 4 or super normal then.
Yes.
So how can you differentiate by going to the aneurysm, right?
Yes.
So you can see here the E prime of the, I'm not sure if you can see the number upstairs. واضح عندكم يا شباب؟
At 5.
Sorry?
5.
5, yes, exactly.
Yes.
So the medial E prime is 5, while the E over E prime in the medial side is almost 30. So this is cannot be normal, am I right?
Yes.
So now we are talking about advanced dysfunction. So
3 to 4.
3 to 4, excellent.
Yes.
So what you have here is the lateral E prime, which is 7, again abnormal. It has to be like 10, 11 or more. What you have here is 7. Okay?
Yes.
So if you want to take these in the diastology, then khalas, for sure there is the advanced diastolic dysfunction. This is just to complete and to show you that by evidence that you have a TR and the TR signal here is 34 in addition to the RA, so the BA pressure will be at least 40 or more.
Yes.
تمام؟ طيب ممتاز يا مشاري. Let's continue. Okay.
Here we see two views. First, on the left, there is long parasternal axis view.
طيب. معلش. اوكي تفضل.
With thickened LV and dilated LV.
Okay.
With pericardial effusion. The valve function, the valve shape looks normal. There is dilated LA in the left side.
Okay.
Right side, this is the four-chamber view. Looks like dilated LA and the RA both.
طيب تمام.
The RV looks a bit not clear. Could be small or
Exactly.
I
If
need
it's
more
not
review
clear,
as well.
don't comment about it.
Yes.
Like, what about the looking of the myocardium itself? How does it look?
It looks like concentrically thickened.
Okay. And is this this brightness, is this a normal to be seen?
This is a sparkling, could be indicative of infiltrative disease like amyloid.
Excellent. So putting all the feature all together, advanced, you have LVH, you have pericardial effusion, atrial dilatation, reduced in the LV function, pericardial effusion, and you have advanced diastolic dysfunction. So as putting all these features together, how can we conclude by single diagnosis?
Amyloid. It will be this is all coded as amyloid disease.
Excellent. So I think there is a lot of finding to code here, and this you can pick the most important, which is, as Dr. Mshari mentioned, he started from the amyloid heart disease, and after that you can go and comment pericardial effusion, left ventricle hypertrophy, and a lot of finding you can find here. Okay. So one more thing that we did for this patient, a strain that confirming what is this shape.
This is the cherry on top strain pattern, and yes.
You can appreciate that there is significant reduction in the longitudinal strain in these patients that spare or partially spare the apex. So this is the cherry on the top, very characteristic for the amyloidosis. ممتاز, excellent يا مشان. طيب. Next, please. Yeah, I just to make it easier, I think this case came last year or the year before. Take your time, look to the view, look to the study, what we are seeing, which valve is this? Is it native or prosthetic valve? And what do you see? What is the finding here? يلا يا شباب. كنت بقول واحد من F3 بس ما شاء الله كلكم F3 الآن. طيب. مين أختار أنا؟ دكتور عمر الغامدي. دكتور عمر. I will help you just tell me what do you see and
I can take this, Doctor.
يلا تفضل يا حامد.
So this is aortic valve. There seems aortic root abscess.
First of all, which view is this, Hamid?
This is a TE.
Okay.
Or sorry, this is mitral. Sorry, this is mitral.
No, you started correctly.
Well,
This is
طيب.
TE, long axis view. What
long axis view is.
Yeah. So we can see here's the mitral.
And here is the aorta.
Okay, excellent.
And
what do you
in
see
the Doppler?
In the color Doppler, yeah.
There is, I think this is abscess.
Okay. So just describe, what do you see? The aortic valve, do you think that this is a native valve or prosthetic?
prosthetic, there is a shadow,
Yes. So
metallic.
shadow is, no, this is not a metallic, it's a bioprosthesis.
Prosthetic.
Okay, you can see that. Maybe in the other view of the short axis will be more clear, but this is a bioprosthesis of the aortic valve. What do you see here? And this is the most important. This is the clue in these cases.
This is there is a flow between this and the I think it is either raw abscess or a fistulation. I don't know.
Excellent. So either it's a fistula, it's either like a pseudoaneurysm or the abscess. You can just describe it that an echo-free space, pulsatile, at the side, at the level of the fibrosa, and beside the aortic valve. What do you see here? That the color that coming through this cavity or the abscess or whatever it is, and there is a significant what? Paravalvular leak.
Paravalvular leak, yes.
So you have paravalvular leak and you have intrinsic leak, both intrinsic AR. Okay. So now, whenever you see the movement, or whenever you see that there is like an abscess formation, even the movement of the aortic valve here, it's look like bulging a little bit up with the systole. So what based on the sheet, what you can comment and what you would
طيب in the sheet بروح على prosthesis valve.
ايوه ممتاز.
نختار aortic bioprosthesis.
ايوه احسنت.
شو اسمه pathological regurgitation لا rocking dehiscence.
Okay. You can choose all. You have bioprosthesis aortic valve, you have pathological regurgitation, and as you mentioned,
rocking dehiscence.
Yes, this is a dehiscence. The rocking, sometimes the movement of the valve will be like more ugly and more significant, but you can say this is a dehiscence. Definitely, this is a dehiscence of the valve in the presence of this fistulation or pseudoaneurysm or whatever is it. So this is a case of the diagnosis is
Infective endocarditis. Yes, endocarditis.
So, you can choose all the findings الموجودة في the prosthetic valve downstairs. You have pathological regurg, you have dehiscence, endocarditis. So this is a case of infective endocarditis with abscess formation of the bioprosthetic aortic valve. يعطيك العافية فهمت.
الله يعافيك.
طبعا this is again shorter. Just to make it more clear, you can see that this is the bioprosthesis. This is not a native aortic valve. This is the abscess, and you can see the flow inside it. How is it? With a significant paravalvular leak and dehiscence of the valve. Come on. So this is the coding as per the sheet. Okay, next. يلا معلش نصعب عليكم شوي. Maybe it's difficult to know what's this view.
Can I take this?
تفضل.
This is a short axis view at the level of the aortic valve. We're looking at the pulmonary valve, the pulmonary trunk and bifurcation.
Excellent.
And large turbulence across the pulmonic valve might suggest pulmonic stenosis. I'd like to see Doppler waves across the pulmonic valve.
Okay, good to start, Doctor. This is short axis view at the level of aortic valve. We concentrate now here in the RVOT and in the pulmonary valve, and after that, the pulmonary trunk. So the question for you, is this systolic, diastolic, or like continuous turbulence?
It's continuous.
And is it in the level, if you expect there is, this is the pulmonary valve, am I right? So it's opening. So if there is a PS, you expect the turbulence to start from here, am I right?
No, to be more central.
Yes.
This one is extending with uniform aliasing, so maybe there is a PDA.
Okay, excellent. It seems that. These, as you said, this is a continuous flow in the systole and in the diastole that's coming from the left pulmonary. So it's below the valve here. So it's unlikely to be pulmonary stenosis, but without looking for the Doppler and for the other views, you could put a differential and you can ask for further. So this is the Doppler. As you could see here, again, continuous flow during the systole and the diastole. And one more, if you want to ask for one more view, Doctor, which view you want to see?
The suprasternal view.
Okay, suprasternal view. Oh, sorry, I think. Probably it was mistakenly we put the same view. However, as you mentioned, it's a BDA. Clearly, in the suprasternal, there was a flow that coming from the pulmonary from the aorta to the pulmonary, consistent with a continuous flow and a case of a BDA. So in the sheet, you can mention this is a BDA case with left to right shunt. And if he brought any other view, you can comment about anything else. If there is like, he brought for you the LV size, the RV size, and the function. But I brought this case just to be familiar and to see the case of the BDA because it might come as a congenital cases. Okay, so I think this is an easy question. This is from the daily practice. يلا يا شباب ونبغى أصوات جديدة. What do you see here? This is an easy one. So this is a transthoracic. Which view is this?
Can I take this, Dr. Yasser?
Yeah, تفضل.
This is apical 3-chamber view showing LV depressed ejection fraction, moderate to severe or severe low ejection fraction.
Excellent.
With apical aneurysm, anterior hypokinesia and posterior hypokinesia as well.
Okay.
I think that's what images view, and I need further images like apical 4-chamber with concentrated in the apex.
Right, that's fine. So, Dr. Abdurrahim, which wall you have here?
It's the anterior, apical, and posterior.
So this is the posterior. Okay,
Yes.
the anterolateral, and this is the anterior septum, am I right? This
Anterior
is
septum, yeah.
You could see that from the mid until the apical part, it's akinetic, completely.
It's akinetic.
Yeah, it's not moving at all. Why the base of the anterior septum is contracting.
It's moving.
As you mentioned, relatively the posterior wall looks hypokinetic. Type. There is severe reduce in the LV function. Ejection fraction approximately here is 30, 35. There is one more finding, Abdurrahim.
There is suspicion of thrombus. That's why I went to another view.
Yes, there is very clear thrombus. You can see that there is a layered thrombus, big one,
yeah,
that at the level of the apex, occupying huge actually. This is occupying all the apex. And this is it's unexpected in the presence of this akinesia and immobile apex. So, for the coding sheet, you comment about
severely reduced ejection fraction.
ممتاز.
Akinetic apex,
Okay.
hypokinetic posterior wall,
تمام.
and anterior septal. LV mass, there is thrombus.
Yes, خلاص, more than enough. Excellent. تمام. So this is a case of anterior eye that get complicated by the LV clot. طيب. Another case. Also, again, this is a case of an MI. What do you see here?
PSR.
This is a PSR, clear, huh? So again, you have aneurysmal apex. You could appreciate in the apical part of the septum that there is a flow coming across the septum with the left to right shunt in presence of this akinesia and the huge aneurysm of the LV. So this is likely a case of ventricular septal rupture. تمام ممتاز. ماشي اعذروني انا ما قاعد افتح الكومنتس الموجودة. So طيب BDA might recalculate. Okay, good. So kinetic LAD territories, severe LV dysfunction, apical thrombus, and a BSR. ممتاز. طيب يلا. Don't be panic if you couldn't find something abnormal. This case came for the echophilus and their OSCE. So just take your time. If you know what's the abnormality,
آخذ أنا
you can tell me what's the diagnosis immediately.
آخذ أنا.
يلا يا حمد.
طيب this is long axis parasternal و good contractility.
تمام.
No, I cannot appreciate any regional wall of motion abnormality.
تمام.
And I cannot visualize the aortic valve. I think it's possibly TAVI or
طيب that's fine.
the RA seems dilated. There is dilated coronary sinus.
أيوة.
Yeah.
Excellent. So you have a dilated coronary sinus.
Yes.
أتوقع يعني هذا الموست يعني shining finding في الفيديو هذا. As you mentioned, there is nothing abnormal here. The RV size is normal. The LV function is normal. The LV contracting looks well. There is no abnormality. The mitral valve doesn't look.
Seems left persistent left SVC.
طيب, why did you say that? Why it's not a simple?
Without a contrast, we cannot judge.
Exactly. So because you have a lot of differential about the dilated coronary sinus starting from pulmonary hypertension, heart failure. But if I want to ask you, you raise the possibility of left persistent SVC, am I right? So what's the test that you want to do?
So we should inject agitated saline.
Okay.
And we see the flow during the echo. If it present only in the RV, this is I think this is not SVC. But if it reach to the RA, it is persistent SVC.
طيب يعني إلى حد ما. طيب أنا I will just correct you. First of all, you have to put the cannula where, ya Hamid? In the left arm, okay?
Left arm, yes.
Because you are looking for the left SVC. If you put it on the right, then the agitated saline is gonna go to the right side of the heart, okay? So you insert your cannula in the left hand or left arm. You inject the agitated saline, and after that, you look carefully. If your agitated saline shown in the coronary sinus first, and after that you could appreciate it in the RV, that confirming the diagnosis of left persistent SVC, okay? So
if it shows in the RV, huh?
It shows first in the coronary sinus. Ideally, whatever you give, either in the left or the right, has to go to the right side of the heart, okay?
Yes.
But in the presence of left persistent SVC, if you
see it first in the
yes, exactly. You see it. You can see that the agitated saline occupying the. We can see it right now. The coronary sinus first, and after that you can see it in the. Right. This is the bubble study. We put that in the left hand. You start to see.
Yes.
أنا خلي الفيديو شغال عشان تشوفونه بشكل واضح. Okay, here you can see it's.
First, it showed in the coronary sign.
And if we want to take it slowly, you see here. Right. Yes, you see here now. Now the coronary sinus is full of agitating, and it's white color. Why the RV still does not show anything? You continue and see now what's will happen. Now starting the contrast start to come after it's been occupied all the coronary sinus first. So, as Hamid mentioned, this is a case of left persistent. How this is a beauty image of the M mode. You put the M mode across the RA to the coronary sinus downstream. You can see this is the agitated saline start to appear here first in the coronary sinus, and after that,
to the
is it clear
RV.
for you?
Yes, yes, clear.
Yes. So, and after that, shown in the RV. So this is the one. This is an extra just example.
How do we code it in the?
That's not in the code sheet. I mean, this is might be just like Pilosky, part of the finding that you'll find. Like it's not in the code sheet. Tamam?
Okay.
So this is an easy. Anyone? So this is a case of off.
Mix up.
Okay, left myxoma.
Myxoma.
Why did you say myxoma? It's not a thrombus. It's not a something else.
It is attached to the tricuspid wall.
To the tricuspid.
Homogeneous.
Okay.
Yes.
It's not attached to the tricuspid. The tricuspid
To the wall,
is
sorry.
it's
To the wall of the.
attached to the intraatrial septum. Okay.
Yeah.
And
moving looks like in a circular.
okay.
Side. All are indicative of right atrial myxoma.
Right. What other finding you can see here? Okay, you need to have four answer. You know.
Pericardial effusion.
Pericardial effusion, dilated
Thickened,
RA.
thickened
Okay.
border. Asymmetrical thickening.
So this myxoma makes some like functional obstruction for the tricuspid valve. As you could see here, that gradient more than 5 suggestive of significant obstruction of the RV inflow. Good. So this is a case of right atrial myxoma with RV inflow obstruction. Right.
Can I take this?
May.
Ahmed.
Yes. طيب we need somebody else. إذا ما في أحد هذا we'll give for you. يلا شباب نبدأ أصوات جديدة.
خذ أنا.
مين؟
فهد.
فهد حياك الله فهد يلا. Go ahead.
طيب apical fourth chamber there is like abnormal mass in the apex of the LV.
Okay.
Is it going with the hypereosinophilic?
Okay, excellent. So you comment that the LV apex is occupied by a mass. Okay, so we can give a differential diagnosis. Such a case, if there is something like this, could you give me 3 different differential diagnoses, Dr. Fahad? What possibility? And how could you differentiate it? Okay, thrombus.
Could be one of the differentials.
Okay, excellent.
Fabry.
Fabry disease. طيب يعني Fabry is not really. Fabry.
Loeffler.
Loeffler is the hypereosinophilic. نعم. What other?
endomyocardial fibrosis.
كلها نفس الشيء.
Endomyocardial.
Yeah.
Could they consider like apical HOCM?
Excellent. Apical HOCM. And you are talking about something that occupy your apex. You need to have like more views. You need to have a sonoview or contrast study just to differentiate between them. So whenever there is like narrowing, suspicious of mass, the LV apex looks like this. So the 3 differential diagnoses will be number 1, as you all of you mentioned, that hypereosinophilic or Loeffler syndrome. The second one is apical HOCM, and the third one, what is it?
The thrombus, we said?
Yeah, لا مو it's not a thrombus, اللي هي non-compaction. Sometimes the non-compaction can have also in between the cribs, you might have a thrombus in between. So you need to look for other reviews and you need to have a contrast study to differentiate between them. So يا فهد إذا تبي تحط في الكودينج وش بتحط؟ You have in the systemic disease, there is hypereosinophilia, endomyocardial fibrosis. This is one. You go, you can put for the LV, you can comment and you put LV mass. تمام? And after that, you can choose any other. طبعا if you put for me an apical HOCM, I will pass it as correct answer. Because as I told you, without contrast, you cannot differentiate between them. Okay? So apical HOCM, if you put non-compaction, LV clot, and hypereosinophilia, all of these are code which can have it. But if he give you more views, just favoring one of them, خلاص just strict to one of the diagnosis and but like they can OSCE and he asks you what's the differential, you give him these three. تمام? Well done, Afad. Okay. يلا يا شباب. This is expected to come.
Can I take this, Dr. Yasser?
تفضل.
So this is a suprasternal view showing strict lesion with flow acceleration.
Okay.
It's showing coarctation of the aorta, distal or thoracic aorta.
Okay. So excellent. Again, Abdurrahim, one by one. What do you see here?
A suprasternal view showing the aorta and the flow.
There is a narrowing in the aorta.
Narrowing in
the
the
subclavian, yes, correct.
With the flow acceleration in this narrowing.
Okay, that's fine. And what make you more convinced to say that this is a coarctation? That if you can see that this color of the flow that is continue to be during the diastole, am I right?
Yes, but the Doppler is
exactly
is more
so
convincing.
You confirm that by asking for a Doppler. So what do you see here, and how could you describe these findings?
Yeah, this is the shape of coarctation of the aorta. It doesn't go back to baseline, and the flow is towards the density is more towards the distal aorta. So it is going with coarctation.
Excellent. First of all, you can see in the systole you have very high velocity.
Yes.
The velocity is more than 4 here, almost reaching to 5. So the gradient gonna be like 90, something like this. Tamam? And what you have also, you have, as Abdurrahim mentioned, there is what we call it the diastolic tail. There is diastolic continuation of the forward flow. You can see high velocity continuation of the forward flow with less velocity during the diastole, but it did not go back to the baseline. So this is what we call it, the diastolic tail. Tamam? This is very characteristic of coarctation of aorta. ممتاز. طبعا this is diagnosis. Definitely he will bring something else to comment about the other finding, but this is I brought this just to be familiar how the Doppler looks in the coarctation of aorta. طيب. Okay. Easy one. يلا.
I can take.
Yes, go ahead.
Anwar, very hugely root.
Okay, excellent. Very huge aortic root.
So we have to see the different views also to see any dissection, mitral lapse.
What do you see also? Comment, and you have mentioned that there is a huge aortic root. What do you have also? What do you think about the aortic valve itself?
Aortic valve itself on the first view looks like okay.
Okay, is it? You can see that there's first failure of coaptation of the both leaflet. That what make These significant aortic regurg, am I right?
Yes.
So because of the
Aortic regurgitation.
yes, so you have dilated aortic root, you have like eccentric, moderately severe aortic regurg. You need to see more view, yeah, Dr. Anwar.
Yes.
Come on, this is a TE view, and just this is a focus,
Yeah.
and this is the lung, or this is the lung axis view, sorry, for the TE, concentrating on the aortic root and the aortic valve. ممتاز. طيب, what else here? Sorry.
So I can see the mitral valve also looks like some prolapse.
Okay.
Anterior leaflet.
Only or both?
Both.
Both leaflets are collapsing.
Yes.
Am I right?
So mitral prolapse,
Mhm.
significant dilated aortic
Mm.
root, aortic
Mhm.
regurgitation, maybe
Okay. So excellent. So putting all these together, presence of significantly dilated aortic root, you have severe or moderately severe aortic regurg, you have bileaflet mitral valve prolapse. So you are talking about a connective tissue disease. Am I right?
Yes.
So in the coding sheet, what you have is a Marfan. So
Yes.
these all feature together favoring of Marfan syndrome. Thank you, Doctor. طيب يلا شباب planning for intervention. A lot of finding in this.
I can take it.
And there is one extra point if you can pick the. Yeah, go ahead. مين معي؟
Abdulaziz.
عبد العزيز. تفضل يا عبد العزيز.
Yes, it's look like global LV dysfunction.
Okay, global.
Yes, with the detached mitral clip and severe MR.
Okay, good. Seems that you have seen this before, am I right?
Yes.
Excellent. So if we assume that there is no, is 100% correct, you can see that there is a device that detach from the posterior leaflet, making very eccentric, significant, or severe mitral regurg. This patient, I need you just to code as per the coding sheet, please. يلا دكتور Aziz. You have a lot of finding. You mentioned it, يعني. You have severe LV dysfunction, severe reduce in the ejection fraction, severe global hypokinesia. Okay.
Yeah.
Okay. There is also aortic regurg. You have dilated both atrium. And if you want, there is an RV lead. This is one of the code. A lot of finding in this. You have LA dilatation, and the LV is dilated also. So the trick here only, or the finding, that there is a clip which was detached. However, if no one comment that, again, in presence of DCM, of dilated cardiomyopathy, you expect to have an apical tether for the both leaflet or apical tenting, and sometimes you expect to have these significant eccentric MR. So, but the extra point here goes for the detached mitral clip. Maybe this is more clear. You can see here that it's attached to the anterior wall, detached from the posterior one, and it's appear also clearly in the short axis view. So excellent, Dr. Aziz.
Can we code ASD?
ASD?
Yes.
Well, if you see it, then it's fine. Well, definitely, if there is like iatrogenic ASD, and it was clearly by the color Doppler, why not? You can code it, yes, no. Okay. So severe LV dysfunction, detached mitral clip. It's not in the code. Severe MR and dilated cardiomyopathy. Okay. I need somebody to comment on this first before going to the other review or the other video. ايش رايكم يا شباب؟ What's the abnormality here? This is one of the code in your sheet. So what's the abnormal thing that you see? We will discuss together, no worries. Tell me, what do you see here? I will give you a clue. There is something inside the R, inside the LA, am I right? So is there an LA mass? Is this like a membrane inside the LA? So what we are dealing with here?
Not thrombus.
Okay, could be thrombus. So do you agree that there is a mass inside the LA?
There is also mass in the aortic.
In the aortic? Like,
Yes, or thickened, I think.
this is about like just some calcification in the aortic valve. But the tricky point here that it's fine for me to start to comment that I can't see like shadow coming like in
It's
and
a
out.
cyst.
You can give a differential here, and you can say that there is what looks like a mass inside the LA, and after that you start to comment about what's the possibility, what the further view that you want to see, confirming or excluding your differential. So that's why I just make the first video playing and did not start the other one. So here, this is a mass, huh? Right. So very simple, by going to the other views, you can tell me what's going on here, صح? يلا. ايش رايكم يا شباب؟ Where
There
is
is
the mass?
interatrial
The common hemorrhage.
aneurysmal interatrial
Yes,
septum.
yes. Who's talking? Yes. صحيح. So what you are seeing here that give you suspicious that there is an LA mass, it's just a part of the aneurysmal symptoms that's coming in and out. Okay? So simply by going here, you can see the LA is clear. There is nothing inside it. And that might like make a trick even in the RV inflow. Sometimes while the technician is doing the scanning, he would come and tell you that I found there is an RA mass. And simply after going to the apical 4, you see clearly that the intraatrial septum is very aneurysmal with like dancing, moving between the both atrium. So whenever you change your view, you can tell clearly that there is no any masses, and this is just a part of the movement of the aneurysmal septum. Okay, so I think it's in the coding sheet. So you can put color just to exclude that there is no any BFO or any shunt coming from this. So what is this? This is a bubble study, agitated saline. We give it and we can see that there is some bubbles across the septum confirming that there is a small BFO. So this is a case of intraatrial septum aneurysm with a bubble study that showed left to right shunt and patent formula valve. It's in the sheet. You can put these three findings: intraatrial aneurysm, left to right shunt, and BFO. طيب. Again, we are talking about TEE. So I am expecting one of the prostheses to come in the exam, either by prosthesis, mechanical. So what do you see here, Shaban? I think it's obvious, huh?
Stuck valve.
Yes, describe it, please.
So we have a TEE picture of mitral valve with the tilting discs.
Okay.
And one of the disc is not moving; it's fixed.
Okay.
With with a high gradient.
Come on. ممتاز. So again, going to the section of the prosthetic valve, you can choose all the finding. You have a stuck valve, first of all, mechanical mitral valve. You have one of the discs that it's not moving at all and stuck. So you can choose stuck valve or stuck disc, and checking the gradient, it's shown that here, I think it's 7 or 9, we can see now. So I'm not really sure it's so fast, but it is a high gradient, as Abdurrahim mentioned. So this is an abnormal high gradient stuck disc and mechanical mitral prosthesis. So we should note, he should give you more views just to clarify more what is the reason of this stuck. Is it like something technical? Is there a thrombus, or is there a vegetation? What's going on with this? But at least I brought this one to show you the stuck valve, because what I hear that it was come in one of the exam before. They brought mechanical valve, one leaflet is moving while the other is not. High gradient, and he asked you at the end, what is this? You have to comment, and this is an stuck mechanical mitral valve. ممتاز. معلش بس خلينا نشوف إذا في أحد كاتب شيء في الشات. سوري طولنا عليكم كنا شباب لنا. I think 2 or 3 cases maybe left.
خذ وقتك انت.
Yeah. ترانس راسك ما هي تي. This case came as an OSCE station in the exam. I need description. If you want to give you history, then we can give history as well. What do you see, Ashraf?
Can I attempt this as well?
Okay.
I'm looking at apical 4 chamber with a thickened mitral valve with hypermobility, especially in anterior leaflet, and a probable prolapse of the posterior. I'm thinking that there's a flail mitral valve and there's significant regurgitation as well.
Okay. Good. Again, could you describe the mitral leaflet for me, please?
The posterior leaflet is prolapsing into the LA.
Okay.
There's a clear coarctation defect, and there's overriding of the leaflets, which is why I think it's a flail segment.
Right. You blame that there is only a flail posterior segment with overshooting or something in the anterior. If I fix the view like this for you, which I fix it?
Here it looks like there's both bi-leaflet redundancy, maybe a leaflet connective tissue pathology.
Okay. Good. So after freezing the image, you can see that both leaflets at their tips, it's so bulky and thickened. Am I right?
Yeah.
So these like morphology or shape is favoring a connective tissue disease, as you said, and what we call
myxomatous change.
not myxomatous. This is one of the differential, definitely, of Libman-Sacks endocarditis. Have you heard about this? That it's commonly coming with connective tissue disease, patient with lupus, scleroderma, rheumatoid. So these both leaflet looks like this. It's a bulky, thickened, maybe at their tips. And definitely there's like some myxomatous change, and the rest of the description, as the doctor mentioned, you can see that clearly there is a flail of the posterior leaflet with very significant or torrential eccentric mitral regurgitation. Tamam? So he might ask you, the scenario was about lady that she's coming with middle age, coming with fever, some like skin rashes, joint pain. So, and he was waiting from you to tell him that there is describe the finding first of all. After that, you tell him that based on the morphology of this, likely this is a Libman-Sacks endocarditis. However, we cannot exclude presence of vegetation or infective endocarditis, especially with this flail posterior leaflet. So you put differential of true vegetation or infected vegetation, Libman-Sacks, all of these. This is again apical 3 chamber. You can see clearly the posterior leaflet is freely mobile inside the LA, favoring the flail leaflet. And the MR in the other view is very eccentric, hitting the anterior wall of the LA. So
Was this exam case?
This was an exam case, but I'm not sure in which year came. But it was one of the OSCE stations. There was a discussion about what is the possibility of the of this. So you, as I told you, you give him the all differential of the masses that attach to the tip of the mitral valve, which might be a true vegetation, it might be thrombus, it might be like a bout of connective tissue degenerative change, all of this. Okay. So it's like an open discussion. He did not ask you about specifically what is the definitive diagnosis. He just asked about the differential. And if he asks you, based on the history, which one likely the diagnosis, so you can answer this is a Libman endocarditis. Tamam? طيب هذا الكيس اللي يحبونه. So quickly يا شباب. What do you see? This is the RV.
Carcinoid.
So carcinoid, Dr. Anwar, why you said carcinoid?
Because the leaflets of the valve was very high as compared to mitral valve.
Okay.
And rated RA.
So is it really high? It's not that
RV.
high. Usually the tricuspid valve is more apical a little bit in comparison with the mitral valve. So, but why you said carcinoid? What's the description of the, what do you see usually in the leaflet of tricuspid in the carcinoid disease?
Thickened.
But yes, thickened. So it's not like far away or not displaced. It's just fixed, thickened, failure of coaptation, very huge coaptation gap between the leaflet, and open TR, as we could see here. Am I right? So this is a case of, this is, I have given this example before, I think. This is a case of carcinoid heart disease. Tamam? طيب, this patient came to me yesterday in the clinic. So luckily that I brought the image immediately. يلا يا شباب. طبعا there is multiple view, but I need single comment about this. What do you see here?
Severe LVH.
Okay. Severe LVH. What else?
Symmetrical.
Okay, concentric or symmetrical.
Possibility of SAM, but we need M-mode.
Okay, excellent. I think the SAM here is very obvious even without a mode. You can see if I
Yes.
like, am I right?
Mhm.
This is very, and one of the very clear SAM that you can see it without even a mode, but as Abdurrahim mentioned, I will show you now the M mode. يلا كمل Abdurrahim. What do you see here?
There is an MR.
Okay.
Also, there is flow acceleration in the LVOT.
Right, ممتاز. What else?
It means LVOT obstruction and dilated coronary sinus. Sorry, dilated aortic sinus.
Not much. Right. So you have concentric LVH. You mentioned that there is a SAM. By looking for the direction of the MR jet. This is again favoring some. This jet is going posteriorly, صح?
Yes.
This is because you have anterior, there is suction of the anterior leaflet. So because of that, the jet is going posterior.
There is AR as well.
There is AR, excellent. So because of the venturi and the high pressure, that making some of the mild or trace aortic regurg. You mentioned that there is LV obstruction. We cannot comment about the obstruction without looking for the gradient. But as you mentioned, you could say that I can appreciate there is some flow acceleration, some aliasing or color turbulence at the LVOT. Going back to the next step, this is again, you can see here very clear the SAM.
Yes.
Okay, so
And the mode showing some, yes.
yes, so you can see here during the systole, the anterior leaflet is sucked toward the septum. And the 2D is very clear, and the SAM confirming that. Tamam?
Mm.
So now what is the next? We need to get the highest gradient across the LVOT. Just
LVOT.
to say that, is there really an obstruction or not?
Obstruction or no? It
So
is
this patient,
52. There
it's
is obstruction.
52 even without doing any provocation or Valsalva. So this patient is very resting gradient of 52 millimeter mercury. So hold the picture together is suggestive of an LVOT obstruction, severe LVH, SAM, so a case of
HOCM with obstruction.
excellent.
HOCM SAM LVOT with obstruction.
ممتاز.
Dr. Yasser, 2 questions, please. In regards to the mitral regurgitation, should we comment in a mid-systolic or the duration بالنسبة للسام؟ في أصل.
معلش مرة ثانية.
هل السام is always mid-systolic mitral regurgitation?
Yeah, طبعا it's usually depend on the sometimes the gradient that you will reach to the maximum. But yeah, likely this is coming before reaching to the late systole. It's like mid systole. It could become late systole as well.
اوكي والسؤال الثاني الجريدينتس هل في cut offs بالنسبة للobstructive HOCM؟
طبعا to say that this is an obstruction, either you have or it's not obstruction, and whenever that you could appreciate a gradient more than 10 in the LVOT, so you start to talk an abnormal or high gradient. But to say that this is significant, then either resting more than 30 or with any provocation or asking the patient to make Valsalva to reach for more than 50 millimeter mercury. So if you were able to get one of them, so this is in favor of severe HOCM or obstruction, unadmitted obstruction. Either at rest 30 or with a provocation more than 50.
Thank you.
Again, this is one of the cases that we have done recently. This is an interesting case, honestly, and not, I would say, not commonly to see. Who can comment here? Yalla Shabab, I think we are reaching to the last 1 or 2 cases left. What's the abnormal finding here? But I will make it easy. The LV is normal, the valve is normal. So what's the abnormal here?
The photo?
So again?
Overriding a photo?
Overriding? Why? There's no overriding. The aorta is opening from the LV. This is the aorta. There's no overriding. Even the aorta is not is normal side, the aortic root.
There's like an echo density line that is in the RV along the superior ventricular septum along with dilated RV.
Okay.
I'd like more view. Maybe this is an Epstein's anomaly.
Okay, excellent, Doctor. So you notice that the RV is not normal in size, am I right? It looks dilated, am I right?
Yeah.
You could appreciate that even the septum is pushed toward the LV. So the comment here from this view that you can mention that there is a significant RV dilatation. Am I right?
نعم
So
صحيح.
you need to know what is the reason. So at one, there is no mass, and this is just maybe brightness or part of the the muscle of the RV, but there is no mass. But here you can say that there is significant RV dilatation. Tamam? Again, this is the another view. Apical fourth chamber, huge RV. Okay, the septum is like paradoxical because of the pressure and inside the RV. The LB is smaller size than the RB. The RA is enlarged as well. D-shaped septum. The septum is pushed toward the LB. And here you can see there was number. I'm not sure if you can see it. I think almost 5 point something. The basal of the RB. The normal, the cutoff is up to 4.1. Here is more than 5. So you are talking about severe dilatation of the RV. طيب الدكتور اللي قال لنا RV, you said that possible Epstein? What do you think?
لا
Right.
هنا ما
The
it looks
tricuspid here looks fine, am I right? So
Yeah,
what's
yeah.
the most common cause of having RV dilatation? You need to
volume
check-
overload,
other than the volume overload. You need
pulmonary
to,
hypertension أو
okay. You need to exclude the presence of shunt, am I right?
نعم صحيح.
So you need to put your color focus on the interatrial septum just to be sure that there is no any ASD. صح?
نعم.
So now I will give you the two view. This is the subcostal view. This is the septum. I couldn't see any color flow across the septum. There is some TR, I would say like mild to moderate TR. The septum again looks intact. صحيح يا شباب?
نعم.
So what, and this TR is not like explaining the RV dilatation, the huge RV. So what is the next step in such case?
Sinus venosus ASD is not
Yeah.
seen in these views.
So you need to go for TE, صحيح يا دكتور?
نعم صحيح.
We need to go for TE. Somebody, Abu Maimuna قال, go to the basal, قال bubbles. Type. Good point to start by bubbles, but clearly there was no shunt. I think that the bubbles done and came to be positive, but the positive was not across the interatrial septum. We have seen the bubbles coming to the other side without clear shunting from the transthoracic. So we decided to take the patient for a TE. What do you see here? As I mentioned in the first two slides in the lecture, which view is this?
This is a bicaval view.
Excellent. This is a bicable view. And what do you see here, Victor?
There's a clear communication between the roof of the LA and the RA at the level of the superior vena cava.
Excellent. So this is your septum. Does not show any like primer or secundum shunt. The IVC here is fine. Here, after we open the SVC, we can see clearly there is like venosus, superior SVC shunt coming with bidirectional flow. Okay, so what's the next step that you need to check to explain or to justify your right side dilatation? Other than this, you need to check for the pulmonary. What's the common association to have a pulmonary drain abnormality? Am I right? So one of the pulmonary vein was draining directly to the RA instead of the LA. So this is one of the rare case that you will face, a case of sinus venosus, SVC with bidirectional flow, small, more than left to right, but here from the color you can see that there is blood coming through up and in both directions. تمام يا شباب. This is another also focus view. You see how big is it, and the IVC, some of these is draining in the LA instead of going to the RA. تمام. So dilated RV, sinus venosus ASD, bidirection shunt, You can in the exam, in the coding sheet, mention just left to right, يعني, if they bring something like this for you. ممتاز. Okay, this slide I have brought this one before. Quickly, what do you see here? طيب.
TAVI.
TAVI. So you have a biprosthesis aortic valve. LV function looks normal. There is some MAC. Am I right? So TAVI valve, you need to go and see the color. Safia Hamid, what do you see now?
There is a paravalvular leak, or there is aortic regurg.
Here is aortic regurg. Is this regurg coming from inside the?
From the side.
From the side. It seems that's coming from the above. Am I right?
Yes.
So it's anterior paravalvular leak. You could confirm that by looking for the short axis is going to be more clear. So this is a repeated slide from the old lectures, just because again, TAVI can come in the exam, paravalvular leak came before. So actually the paravalvular leak came in my exam, like a couple of years back in the F3. طيب. Last slide.
هذه إبشتاين.
Okay, clear, huh? So
Yeah.
here it's very clear that in comparison with the previous one, you see how is the gap between the left hand and the right valves. So the mitral is here, while the anterior leaflet of the tricuspid is significantly displaced. How much Dr. لازم تكون to fit the criteria of Epstein? The apical displacement of the...
More than 8 millimeters.
Yes, it's indexed. Am I right?
Yes.
So 8 millimeter per square. So a case you have huge, as per the coding sheet, you can comment about severe enlargement of the RA, small size RV. You have apical displacement of the tricuspid valve. This is the color. Severe tricuspid regurg. So as a systemic diagnosis, you can say that this is a case of Epstein anomaly. It does. واضحة؟ طيب جميل. I think by this I conclude. أتمنى إن شاء الله تعالى أن يكون cases يعني was enjoyable with the finding that I brought for you. I wish a successful exam for everyone. طمنونا عنكم بعد ما تخلصون بالتوفيق جميعا إن شاء الله.